Helping our patients manage their immune health has never been as important as now. Hi, it's Lisa Costabir, and you are invited to my upcoming live and online masterclass on how to build immune fitness and manage acute viral infections. You can catch this masterclass on May 11 as part of the Bioceuticals Clinical Mastery Series. If you are looking for more evidence-based strategies for maintaining optimal immune health, reserve your place now. bioceuticals.com.au.
This is FX Medicine, bringing you the latest in evidence-based, integrative, functional and complementary medicine. I'm Dr. Damian Kristoff, a Melbourne-based chiropractor and naturopath, and joining us today is Dr. Andrea Huddleston. She's a women's health, natural fertility expert and integrative chiropractor practicing in Perth. She's the co-host of the award-winning, top-rated podcast Wellness Women Radio and is affectionately referred to as the period whisperer by her patients. In addition to her chiropractic degrees, Dr. Andrea holds 2 postgraduate master's degrees in women's health medicine and reproductive medicine. She's a leader in women's health, a great friend of mine, sought-after presenter, avid coffee addict, and a crazy dog lady. Thank you for joining us today, Andrea.
Thank you so much, Damian. I'm super happy to be here.
Great. Hey, Andrea, when we look around and we you and I see a broad range of different patients, and I suppose these days you've really narrowed, I suppose, not narrowed, but you're very specific. You know, people come to you because of hormone dysregulation. You're known as the period whisperer for a reason. Like there's a reason why you're known as the hormone whisperer and the period whisperer. So we're seeing record levels of reproductive dysfunction, more than ever before. What are your thoughts on this? What's the problem? What's going on?
That's such a good question. And I think just like any other chronic health condition, I think it's because our current lifestyles just aren't conducive for optimal hormonal function, right? Or optimal reproductive function. And I always like to think of the menstrual cycle as being, or it should be considered really, that 5th vital sign. So just as an important marker of health for women as is something like their own blood pressure, because it gives us this clue into the overall health of that woman and the well-being of that woman as well. And this is not just for cycling women in their reproductive years. This is also as we transition into, say, perimenopause and menopause. The longer we cycle for example, really dictates the health of women, later in life. And if we want to get really specific about the things that I think are causing so much of this reproductive dysfunction, I sort of oversimplify things into what I think are the main causative factors of hormonal dysfunction, and I call them my 5 S's of hormonal imbalances. And the first part of that, Damo, if you want to sort of get started on that straight away, we can dive into that. So my first S of that is stress, right? And
no stress, no stress at the moment, is there? No stress anywhere.
No, nothing. Especially not over here in Western Australia, right? We're so stress-free, it's ridiculous. And, we're all under unprecedented, amounts of stress and pressure at the moment. But this was occurring well before the pandemic hit even. And I think the amount of pressure on women and the amount that we take on and the lack of balance that we have in our lives and everything else certainly contributes to just the breakdown of our system. And even if we just look at from, say, like a biochemical level, if we're under that chronic stress, we're producing lots and lots of cortisol, then we're robbing progesterone to make more cortisol, and then we're getting this unregulated, ratios between estrogen and progesterone, and then our thyroids are shutting down. And, I sort of explain to my patients that whole stress hormone cycle so that they can really understand that just from the pressure at work or just from constantly rushing around, all of those things can be why their hormones are so all over the place and why we're seeing such statistics of almost every woman with some sort of hormonal dysfunction. It's a pretty sad state of affairs, I think, for women's health at the moment. So stress,
Would you say that pretty much every woman has some kind of hormone dysfunction? Is that what you're saying? So like whether it be acne, whether it be period pain, whether it be endometriosis, whether it be PCOS, whether it be amenorrhea, dysmenorrhea, whatever, like shortened cycle, lengthened cycle, pain on menstruation, stress on menstruation, emotions on menstruation. Would you say that pretty much every woman's got some kind of dysregulation?
Look, and I think that the subsect or the sample of patients that I see probably makes me a little biased in this, but I really do think that is the case, because if we look at statistically, they say about 1 in 9 women have, say, endometriosis. I think it should be a bit higher than that, but let's just round up and say about 10%. Up to 21% of women have PCOS. And those two conditions rarely overlap. So that's like 30% of the population now. About 1 in 4 women have some sort of fertility challenge. And then I'm sure, Damian, you experience this as well. Like, I'm seeing thyroid conditions pop up in almost, epidemic proportions, especially after women have had, their second or third baby. And then, finally, women who experience period pain that is enough to be, interfere with their activities of daily living or require pain medication is like 95% of women. That's just period pain. So statistically, that's more than
every woman.
I know. That was a terrible percentage that I was going on. But even just in that first section, that's at least 30% of women who have some sort of diagnosable hormonal interference. So, and there's certainly reasons for this as well. And, certainly stress is one of them. But I think this is also the way that women have been treated within, the standard Western medical model. And the treatment approach to that, I think, can be part of why we're seeing such dysfunction these days as well.
Cool. I mean, we're talking kind of almost organic, or we're talking more about biochemistry here. And when we talk about stress, that's a autonomic nervous system function, right? So stress in itself is an autonomic nervous system function. So we know that that's brain derived. The brain is signaling, it's feeding forward, feeding back, it's receiving information, sending information. That comes from the brain and the spinal cord, right? So we're talking about a neurological function, but often we're talking about the management of it with biochemistry. And to me, there seems to be a little bit of a disconnect, but where I kind of want to, go with that is that for much of what we talk about in terms of the management of these issues, particularly in and around stress, and we'll come back to all the other S's shortly. But when we look at this, we kind of go, okay, well then, as a naturopath, I've got my naturopath hat on here, right? And I think about, how do I manage the autonomic nervous system? I might throw magnesium at it. I might throw some herbs at it. I might throw maybe some behavioural changes, whether it be walking or meditation or some other different things. If I put a medical hat on, I might look at anti-anxiety medication or sleep medication or whatever else. So there's these biochemical influences over that. But there's food that is biochemical. There's pharmaceutical and nutraceutical and phytoceutical interventions that we might consider. But we're talking neurology here, right? We're talking about the nervous system and the brain. So can we delve into that a little bit? Can we talk a bit more about that?
I would love to. And Damian, you are going to be so much more succinct at explaining this sort of thing than what I am. But I know for my patients, for example, part of the way that we would address the chronic stress would certainly be through all the avenues that you've just discussed. We might use herbs, we might use lifestyle and dietary interventions, and, looking at what the root cause of those triggers are and everything else. But then the other intervention that we have is obviously adjusting them. And from the way that I experience their changes with that is that they then experience their environment and those stresses differently. And even if we just look at how, because obviously we're talking about, women's health and reproductive and, hormonal function, the uterus itself is under autonomic control. So therefore, changes in the nervous system is absolutely going to change how the uterus is functioning, which will then have a flow-on effect to how the ovaries are functioning, because we need that functional uterus for adequate ovarian function as well. Yes. I've said that word too much now, but...
it's a functional medicine podcast, FX Med, so it's functional.
Yeah, that's very true. But we need that brain-body connection to be working adequately for, optimal function.
Yeah, that's a great point. And so when we think about that in terms of distortion, so we're talking about dysfunction or in say an autonomic nervous system sense, or dysfunction in terms of dysregulation of the hormones, they're very closely related and easy for us as chiropractors and us who are well versed in both the biochemistry and the neurology of all of that. It's easy for us to kind of see that. But how do we explain that to our patients? Like, how do we explain that? Let's say I'm a naturopath right now, or an integrated GP right now. How do I explain that? Yes, there is a biochemical component, but the brain controls all of that. The brain is your master controller in this sense. It's under autonomic control. Is there a way in which we can explain that easily?
I think the way you just did that sounded really succinct to me, Damian. That was beautiful,
There it is.
In its most simplistic way, it is the brain that is the control mechanism of everything. And so if we don't have that brain-body connection happening, then, what are we going to see that changes after that?
Yeah.
And I know that even if we look at, and maybe we'll get into this shortly, but one of my my 5 S's of hormonal imbalances or hormonal problems is actually spinal problems. And it was just handy that spine starts with an S. So it's included in my 5 S's. But it really is, for what I see in practice and my interpretation of, the issues that we're seeing in women's health, the posture of a woman and the pelvic position and, pelvic distortion patterns and everything else dramatically influences, for example, menstrual health. And this is documented. There is research that supports this as well. And it's something that I see in practice every day. Damian, should we dive into a little bit more about that now?
I'm so glad you said that, because that's where I wanted to go, because I thought, oh, great, You've brought that up. So let's go into that. So I was going to ask you, is there a link to the health of the pelvis and pelvic distortion? That's the question. And I'd love us to just kind of head that direction, because you've gone to that S. Let's head there.
This is one of the most fascinating things that I find in women at the moment, and I'm a little bit obsessed with it, and that is this idea of pelvic position and how it relates to uterine position. And really simply, without going into super in-depth anatomy, the uterus is not really attached to anything. It's suspended within ligaments that anchor into the pelvic bowl, and the most important ones that really maintain that uterine position, and I'll bring it back to why that's relevant shortly, is the uterosacral ligament, which attaches into the front of the sacrum and then to the cervix, and then there's the cardinal ligaments that go from the cervix to the base of the pelvis or the ischium, and then the pubocervical ligaments that go from the cervix to the pubic symphysis. So I'm moving my hands to try and show you, but I realise this is audio, so that's not helpful at all. But
we might need some pictures. We'll get a diagram to everybody. Go to the show notes. Don't forget to go to the show notes and get these diagrams, because they're great diagrams. They're awesome.
Yeah. Totally. I'll send you those for sure. So I want you to understand that the uterus is suspended within those ligamentous structures, and about 75 to 80% of women have an anterior pelvic tilt, or that forward pelvic tilt. And I don't think it's a coincidence that same percentage of the population also have an anteverted uterus, so that forward tilting uterus. And the reason that this is important is because when women menstruate, part of the movement of and the flow of blood with menstruation is simply with gravity, and it's with those uterine contractions that happen to expel the blood. However, if you have more increased flexion of the uterus in either anteversion or retroversion, so backwards tilting, then that blood pools in that front surface of the uterus, which means that it requires stronger myometrial contractions to actually expel that blood, and that those myometrial contractions are cramps. They're period cramps. That's the period pain, or a big portion of the period pain that women experience during their period. And it's a biomechanical positional issue of the uterus when we've got a pelvis that's sitting in that sort of forward flexed, a position, and then we've got the uterus, which is also anteverted, and it might be anti-flexed or anything like that. Or if we've also got a retroverted uterus, but it's the degree of flexion in either anteversion or retroversion, which is an independent risk factor for dysmenorrhea or period pain. And it's not associated with pregnancy. So this is independent of those things that we know that period pain goes up according to that degree of flexion. So that optimal uterine position, which is dictated by optimal pelvic position, equals better menstrual health, less painful periods. And then we can sort of expand that to possibly better reproductive function as well.
Wow. This is mind-blowing. I'm a chiropractor. I know this stuff, but hearing it is unbelievable. Like, this is so good. And I wish this was live and we were going out to the millions of listeners that we do have. And we were, and I was watching those little light bulbs go off, because people will be going, oh my gosh. Like, this isn't just a simple Vitex issue. This could be a positional issue. And this is absolutely fascinating. So, you're saying...
Yeah, and there's hints that the practitioners can look for as well, because, you may not know if your patient has, say, an anteverted or a retroverted uterus, but this is something that I think should be part of a clinical consideration whenever there is a complaint of, for example, primary dysmenorrhea, or even just any kind of menstrual-associated pain like that is in the instance of endometriosis as well. I think that this always needs to be looked at or addressed because of the prevalence. And so, Damian, I can talk through some really easy symptom pictures that they may be able to look for to help differentiate, say, an anteverted versus a retroverted uterus, if that would be helpful.
Yeah, let's do that, because I know everyone's going to want to know, how do I know that it's not just a progesterone issue? That's what they're going to be asking.
Yeah, okay.
I've simplified that. I've made that really basic, and that's probably not everyone's asking. But I'm going, how do we add an extra layer there? What are we looking for to kind of understand? Where should our clinical thought go? How do we reason with this to decide what's the cause of someone's dysmenorrhea?
So I think, obviously a really thorough history taking around that and understanding the quality and the timing of the pain as well. Mm-hmm. So normally one of the biggest indications that I see with a patient who has a positional issue that's contributing to her period pain is she will get pain and cramping before the bleeding starts. And because it's almost like the body is trying to expel that blood, but there's that structural component to it where things aren't moving as well. And obviously, we've got to address things like the prostaglandin release and hormonal imbalances and everything else along the way. But this is such a huge part of that. And with an anteverted uterus, and yes, anatomically the uterus sits slightly anteverted anyway, but as it increases in that anteversion, you might get that classic anterior pelvic pain. The patient might describe dragging into their legs. They may get pain into the vagina or the low back, sometimes during sex as well. They may have trouble inserting tampons, but they might feel some sort of internal pressure even with proper insertion. Mm-hmm. As they're getting or building up to their period, they might notice increased urinary frequency or getting that fullness of their bladder as well. So they'll feel that pressure of obviously the anterior structures of the uterus pushing into the bladder. They might have high rates of things like UTIs. They might get, mild incontinence, but also you might actually just see on them that they might have that little pooch or that protrusion of that lower abdominal area.
Yeah, and, which is very common. It's very common these days. If 75% of women have an anteverted pelvis, then that's got to be. That's more common than uncommon.
Exactly, yeah. And women will often come in with, ultrasound reports and that describes the position of the uterus. So that's, a little bit of a cheat sheet for us. But if you're pretty skilled, you can also palpate the position of it too. And just with a symptom picture, it's really easy to differentiate, what you're dealing with, whether it's an anteverted, anti-flex uterus or a retroverted. And I find that a retroverted uterus is much more of a almost pathological condition. So the reasons why a woman might have a retroverted uterus is often from things like infections. It might be uterine scarring from infections like pelvic inflammatory disease, STIs. It can be obviously from endometriosis, adhesions as well. It can be
one thing we don't talk about in that regard with regards to scarring. Could abortions have anything to do with that? Could there be anything else? Maybe scraping the uterus to, reset, or to, there's all these different types of interventions. Like, is it just, no one talks about that. Could that be something?
Oh, excellent question, Damian. I actually haven't looked into the role of like the DNC, for example, and what kind of scarring and whether or not there's adhesion formation from that. I'm not sure, but that's definitely something that I'm going to look into because you've piqued my interest there.
Yeah, I just wonder, because it's happening more and more. It's not maybe not more and more, but it's happening, and so could that be something that we miss in our clinical diagnosis and our note-taking? How many of us are asking what sort of surgeries have you had, and do we just gloss over the potential that might actually have something to do with it?
And certainly the more like laparoscopic surgeries that a woman might have is certainly going to increase scar and adhesion formation. We know that. And while that is obviously still the gold standard medical treatment option for endometriosis, there's pros and cons there, right?
Yeah, totally.
Women can also have a retroverted uterus from like big falls on their sacrum, and just poor pelvic alignment from chronic high heel wearing, poor like.
They look so good though. They look so good. High heels. That's the thing that I get. When I mention that to ladies, high heels could be involved, could be part of the problem, and they're like, but they look so good. I'm not ready to give up high heels yet, So that's often something that I get told.
Yeah, and I totally understand, and I'm probably as vain as they come, but you have to really weigh up the, can you fence sit with this? And if you have severe period pain, I would expect that, you can ditch your high heels for a while, but, if that's indicated, that's just my take on it anyway. My patients know that they cannot wear heels into my practice, otherwise they have to leave barefoot. But also I'm a bit of a hypocrite because whenever I'm teaching, for example, and Damian, you would have seen this, I'm always in super high heels. But I think that's part of the outfit, right? Helps get you in the zone. And some of the signs and symptoms that practitioners may be able to sort of tease out to determine whether or not this patient may be looking at more sort of a retroverted or retroflexed uterus. Normally I see much stronger period pain with this position, and you'll get normally low back pain during the period rather than just that classic anterior pelvic pain. You can get changes in bowel movements as well during the period. So women might explain things like constipation or really thin stools before the period. And because obviously like the uterus grows so significantly in volume just before menstruation, and it pushes into the back of the rectum. So that's why just their bowel movements can change. And it will be so much heavier if there's something like, meiosis or sort of fibroids that are present too.
Yeah, right.
Some women can even experience really foul-smelling menstruation because in that position with that heaviness on the rectum, they can actually get sort of toxins from the bowel seeping into the uterus as well.
Right. Wow.
We normally see more fertility challenges with a retroverted uterus. We see a more common occurrence of things like sciatica as well.
Around the period time?
Yeah. So that cyclical sciatica, I think, is a really big red flag for either endometriosis or retroverted uterus. And we'll often see more like ovulation pain and normally more advanced endometriosis. I will see a retroverted uterus as well.
Wow,
so
this is big. I reckon people are going to be rewinding this and taking notes and going, I'll go back 15 seconds. When you want the podcast to go back 1 minute, not 15 seconds at a time, I reckon that's what they're going to want to do to get all these little nuggets that you're sharing with us, Andrea. This is absolutely amazing. So it's pretty clear that there's a pelvic distortion component to what our female patients could be feeling if they're coming to see us with dysmenorrhea. What about amenorrhea? Is that also similarly related, or could that just be purely hormonal? And then if it is purely hormonal, is that also under autonomic control?
Well, the uterus and the ovaries are under autonomic control. So I think that if there's autonomic dysregulation, it's reasonable to see women with either heavier periods, more painful periods, or even absent periods. So, like, for example, and just to get like super nerdy, the uterus is is sympathetically by the uterovaginal plexus, and parasympathetically from S2 to S4 from the sacrum. So, you know, that's why, like, big falls on the sacrum, any irritation of those nerves is obviously going to change that. And the reason that is like so important is because contractions in the uterus, so for example during childbirth or menstruation, to expel the blood or whatever we're trying to achieve, there is a stop-go system. So we need that balance between the parasympathetic and sympathetic nervous system. Does that make sense? And I'll cycle back to amenorrhea in a second.
Yeah, it does. And I think it's good for everyone just to kind of let's bring everyone back up to speed with that one again, because you just called it a stop-go system. So we go that either going parasympathetic or sympathetic. Is that what you're saying? So we're going it's on or off, or maybe you just explain that a bit better so that I can get my words right too.
So essentially we need balance between the parasympathetic and sympathetic nervous system to be able to control that properly. So, for example, if the hypogastric plexus is stimulated too much, then we're getting intense contractions during the period. We're getting intense cramping. We're getting more excessive blood flow. Does that make sense?
It does, yeah.
And the uterus is so important even though it's not a hormone-producing organ, we need a functional uterus for proper ovarian function. And I think that this is so critical for women who may be considering, say, a hysterectomy, because the blood supply, lymphatic flow and nerve supply that goes to the ovaries goes to the uterus first and comes from the uterus as well. And obviously our ovaries are our main hormone-producing, organs, or our primary sex organs in menstruating women. And then obviously as we transition through that midlife time into perimenopause and menopause, our adrenal glands and our peripheral tissue takes over the production of those hormones. But during, obviously puberty and our fertile years, our ovaries are responsible for that. And so we need that proper innovation for that proper control of the uterus to also control ovarian function too, and hence hormonal production. Does that kind of make sense?
Yeah, totally makes sense.
Okay.
I'm stuck on the 75% of women have an anteverted uterus, or was it uterus? Yeah, anteverted uterus. I'm stuck on that. And the reason I'm stuck on that is because I think about we have an increasing rate of weight gain, and we see a lot of obesity, and that forward carriage of weight through the abdomen into the pelvis. Could that also be something that's related? And I want to go back to falls and slips and that sort of thing, accidents to the coccyx, but like these postural distortions as a result of where we carry weight or where women carry weight, could that be related?
Oh, Damian, absolutely. And dramatically as well. And we also see women who are overweight or obese have much heavier and often more painful periods, because part of what happens within the uterus when you're menstruating is the uterine lining repairs itself, almost instantaneously as we get that shedding. Whereas with the increased body weight, there's this increase in oxidative stress, so that that healing of that uterine lining is so much slower.
Right.
So we get so much more bleeding, so much more pain, and that's related to obesity, and it's related to that excess body tissue as well. So certainly there's a postural issue there. There's purely just a body tissue kind of issue there that's driving that oxidative stress and everything else. But I find that some of my more obese patients struggle more with period pain because of purely that uterine position issue, and it's much harder to correct as well.
And could it also be, let's going back to the biochemical thing, given that we know that body fat secretes interleukin 6, I think it is, and estrogen, and there's a hormonal component of control with body fat and there's got to be some kind of biochemical component to that, as well as the postural and neurological distortion thing there. So it's two-pronged, double-pronged, where we've got like a metabolic issue that needs addressing.
Yeah.
So we've got to definitely make sure that we're helping our patients get the weight off and explain to them that this has hormonal influence, et cetera, but also then explain to them that the weight itself and where it sits has an impact on the position of the uterus and the position of the pelvis, and therefore both things, like we're talking biochemical and neurological / structural, could be influencing these patients' symptoms.
Absolutely. And I sort of try to explain to my patients that excess body tissue is its own endocrine producing organ. Yeah. So this is where we're getting, sometimes those toxic levels of, estrogen, for example, that's so unregulated, and it's so difficult for the system to be metabolizing, when they are really overweight. So obviously diet and lifestyle and everything else that comes into play with looking after a patient holistically is critical.
Crucial, absolutely crucial. I want to go back just a step, Andrea. You mentioned before falls on the coccyx. And, obviously children fall all the time, but, sometimes you hear of an injury that took place at the age of 8 years old where the little girl fell off or slipped off the seat of a bike and, hit her coccyx on the crossbar of the bike and broke the coccyx. And then that's kind of, people just go, oh, don't worry, the coccyx will heal itself. But could that be related to, some of this dysfunction in the pelvis? And then what would have happened had that been corrected earlier on, like if it was related?
That's a really great example of that coccyx issue, because normally once you fracture a coccyx, particularly if it kind of sits at that 90-degree angle anteriorly, that's a pretty tricky thing to heal, and it's kind of stuck like that, really. And and my understanding of that, I'm thinking of those sacrotuberous ligaments that obviously anchor into the base of the coccyx and then down to the base of the pelvis as well. And when all of that is disrupted, they're part of the stabilizing structure for the actual sacrum. And so when that sacrum is distorted, particularly if we've got, like rotational issues through the sacrum, that's also creating that rotational distortion pattern through the uterus too, which is going to be affecting, obviously uterine position, but also blood, nerve, and lymphatic flow to that area. This just came to my mind, so I'm just going to share it with you. But the sacrum means sacred or holy bone, and I just love that because I think it's the keystone to the whole, the way I see it, all of that pelvic health as well. So if we've got a little girl who had a big fall, when she was really, really young, and her body has, there hasn't been sort of any, any ways to address that, then we know that that's certainly going to be turning into a chronic issue. And the longer something has been there for, the more adaptation that the body has created to overcompensate for that, really. And normally with coccyx issues, you'll see either a dramatically anterior or posterior sacrum. In my experience, that's just what I've seen in my patients, and when I've looked at X-rays and those sorts of things of patients as well who've had those big coccyx injuries. And the longer it's been there for, the more adaptation, so the harder it is, and the longer it's going to take to change.
Well, that kind of makes sense. So we then start to talk about the link between an acute dysfunction and a chronic dysfunction, the length of time between something being checked and, then brought to attention and regulated or managed really well could have a significant role to play in the reproductive health, and certainly, definitely the reproductive health of that particular person, that girl, that young girl, even the young lady.
Yeah, absolutely. And we know that, for example, a retroverted uterus is a risk factor for infertility, and pelvic distortion that might happen in, or pelvic like organ distortion that might happen in, say, something like endometriosis, for example. We know that is a risk factor, and it's called the so-called pelvic factor that increases the risk of infertility for patients with endo. And that's observed, like a really common observation in laparoscopic surgeries as well. So those adhesions that form that distort the position of the uterus and can also distort, for example, the sacral position, can change how the oocyte is released from the ovary. It can change how the ovum is actually picked up in the fallopian tube, and it can impede that ovum transport as well. And I think that they even showed, there was a study that showed that in monkeys, which is probably, I guess, the closest thing to a human study really, that in monkeys with endometriosis, that it showed that their fertility was impaired because of those pelvic adhesions, and because it also affected like follicle rupture, and that's also because of that pelvic distortion pattern.
Yeah.
So
I'm blown away that monkeys get endometriosis as well. Like that,
I know, isn't that terrifying?
That's got me. That's got me.
I can't remember if it was this is a long time ago that I read this, but I'll have to dig it out. I can't remember if there was a causation for this, if they were given endometriosis essentially in the first place.
Wow.
And then that was assessed.
Okay, unbelievable. Now, we haven't got a whole lot of time to go, but I think we could probably make this we could do a second part to this particular interview, and I reckon that might be worthwhile because there's a lot of more information that I think we need to get from you, because we've only done 2 of the 5 S's so far. There's a lot more to go.
Know.
So we did talk about cortisol, and you were touching on a new, I suppose, approach to the understanding of what could be going on, and that's unregulated inflammation as a result of hypercortisolemia. And I think that's where you were going with that. Is that something that we've got time to discuss now, or should we come back to that in another episode?
Damian, that's such a good question. So there is some new... let me get started, and then you can tell me if you want to go down that rabbit hole. I might pre-top it
Okay.
there, because what I really want people to understand is that there is a direct connection between pain and hormones. So, and there's this saying that I have, is that adequate pain control cannot be achieved without hormonal homeostasis. So hormone levels actually serve as biomarkers of uncontrolled pain. And, like personally, clinically in practice, I actually find pain so boring. It doesn't interest me at all, but I know it certainly interests a lot of patients.
Yes.
But now that I've sort of looked at the other dimensions of pain, I find it a hell of a lot more fascinating. And there is this new emerging research that shows that major pain control mechanisms of each sex hormone in the steroidogenic pathway has actions of pain modulation, so including things like immune modulation, like anti-inflammatory action, cell protection, tissue regeneration, even like glucose control, which is affected by pain as well. And that hormones also, like particularly estrogen, they modulate the central nervous system receptors and nerve conduction too. So this is certainly very much like a two-way street. And if we look at, say, I think a really great example of this is how estrogen can be either pro-inflammatory and pro-nociceptive.
Yes.
Or it can be anti-inflammatory and anti-nociceptive, depending on its balance. So
the balance of estrogen versus progesterone and testosterone, for example, or the balance of estrogen versus cortisol and adrenaline? Or is it all of it? Like, are we talking like this big HPA?
Because we know that obviously no hormone acts independently, and it is that, I think we always refer to it as that hormonal symphony orchestra of balance, and cortisol is certainly the conductor. I think I heard someone say is the conductor of that orchestra, which I think is really accurate.
Yes.
But estrogen is either pro or anti-inflammatory and nociceptive, just depending on the phase of the cycle and its balance, and obviously the body's ability to metabolize it correctly. Mm-hmm. Whereas testosterone appears to be pain protective. So it has mostly anti-nociceptive actions and can down-regulate the activity of estrogen receptors in the brain. Mm-hmm. So I think this is super important for men as well, because that means that low or deficient testosterone levels are linked to higher risks for, all sorts of chronic pain states, and inflammatory, like, nociceptive nervous system stuff that goes on. But also for men who may be aromatizing testosterone into estrogen too quickly, that would be part of why we see those painful inflammatory conditions in those men with lower pain thresholds. Damian, do you see that in practice as well?
Yeah, totally. Yeah, you definitely see some men come into the practice. They may be carrying a bit more weight in and around the middle areas of their belly, and we do know that men can carry a lot more, kind of visceral fat, and, to the tune of, say, 20 kilograms more than what women can. And that is a huge hormone impactor and influencer. And definitely you see those men who are very sensitive to pain. It could be a tiny little thing that's not right and they're in a lot of pain. So, yeah, I definitely see that in practice, no doubt about it. And it makes a lot of sense too with the women that are hypersensitive. Sometimes you can have an obese lady lying on the table and you just lay your hand on that person and she's jumping off the table.
Yes.
And so there's that hyper sensitivity that you kind of go, this is weird, but it just kind of makes sense with this new emerging research that you're talking about. Fascinating.
And when it comes to cortisol, Damian, without going into, there's so much there around cortisol and how, that whole hypothalamic, pituitary, adrenal, ovarian, thyroid axis is sort of stimulated with stress and pain. But in this stimulation phase of severe pain, hormone levels initially go up. Mm-hmm. But if the pain persists, so cortisol goes up, right? In response to that pain, there's a threat, and that's what that pain response is. And if the pain persists, that hormonal system is usually unable to tolerate the stress of the pain. So then we get this reduction in that, which then gives us this reflexive kind of low cortisol picture, which is actually the most serious hormonal complication of severe chronic pain, and that's its negative impact on cortisol. And women with chronic pelvic pain, for example, actually demonstrate low cortisol levels rather than those with acute pain who originally had high levels. So women with chronic pelvic pain have hormone levels that are consistent with prolonged, consistent stress. I just find that so interesting.
Out. This is so unbelievable. This is so unbelievable. There's a lot more that I'd love to discuss with you. And I think that we could probably make a second episode of this, and I'll go to the bosses and I'll ask them, can we get Andrea back on for another one? And if you're listening to this and you're wondering, oh my gosh, there's so much more that I want to learn from Dr. Andrea, please do another podcast, then send us some feedback, let us know. But I think, Andrea, we've come really close to time, and I'm going to have to call it on this one because there's still 3 S's that we've got to get through, and I just know there's so much that we can cover, including timing and why do people go to a chiropractor and why do they go for a long time, or is it just a short-term thing? And so I really want to cover that off, but I think we should, to do that justice, come back and do that in another podcast. Will you come back on and do another podcast with me, Andrea?
Oh, Damian, I would love to. Yeah.
That'd be great. Well, I think we'll leave it at that for today because we're going to run out of time, and we'll bring you back on for a part 2, Andrea. And I know that people will be chomping at the bit to listen to you again. But Andrea, that information today was unbelievable. Thank you so much for joining us on FX Medicine. It's been an incredible interview. Thank you, Andrea.
Oh, Damo, thanks so much for having me. It's a pleasure.
To get more information about Dr. Andrea, head to drandrea.com.au or wellnesswomenradio.com. Thanks everyone for joining us today. Don't forget that you can find all the show notes, transcripts and other resources on the FX Medicine website. I'm Dr. Damian Kristoff. Thanks for joining us.
This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.
Hi, this is Damian again. Join us next week on FX Medicine for part 2 of this series on the biomechanics of reproductive health with Dr. Andrea Huddleston. Subscribe to us on your favourite podcast app and follow us on social media to make sure you never miss an episode.